Hi everybody, this is Mazen Judi, Assistant Professor in the Baghdad Medical College. By the name of God, I would like to present this lecture about the management of localized prostate cancer as one in the Oncology Made Easy series. The objectives for this lecture is the risk stratification of localized prostate cancer depending on certain criteria and discussion of the different modalities for treatment of the localized prostate cancer. The optimal treatment of prostate cancer requires assessment of risk by answers for specific questions. These are is how likely is a given cancer to be confined to the prostate or spread to the regional lymph node? So to assess the stage of the prostate cancer. The other question is how likely is the cancer to progress or metastasize after treatment? And the other question is how likely is adjuvant or salvage radiation to control the cancer after unsuccessful radical prostatectomy? Regarding the risk classification for clinically localized disease, we depend on specific criteria, and this best characterized by digital rectal examination, radiographically determined clinical T stage, the Gleason score, which is the histopathological features and specific score, the extent of the cancer in the biopsy specimen, the serum PSA level, and these are the most important criteria on which we depend for the risk stratification of the localized prostate cancer. Imaging studies like ultrasound have been investigated intensively, but have yet to be accepted as essential for the staging of the prostate cancer. Now, there are many treatment options for the localized prostate cancer, include the observation, active surveillance, surgery, radiotherapy, and also hormonal therapy, in addition of certain trials for other modalities like cryotherapy and others. What option is choice or the choice of which option for the treatment of the localized prostate cancer depend on the risk of this cancer. The risk stratification different in different oncology textbooks and guidelines. In the ASCO guideline, they stratify the localized prostate cancer into three major risk groups, which are low, intermediate, and high. While the NCCN guideline, they classify or stratify the risk for the prostate cancer into six groups, which are very low, favorable, intermediate, and unfavorable, intermediate, high, and very high risk groups. We'll discuss each group and the treatment for this group. Let's start with the very low risk group. What are the characters for very low risk group prostate cancer? It is characterized by being gathering of certain criteria, which first one is T1C. T1C means that the tumor identified by needle biopsy found in one or both sites but not palpable. This is the T1C. The other character is the Gleason score equal or less than 6, which is grade group 1. And the other character is PSA less than 10 nanogram per ml. And the other character fewer than 3 prostate biopsy fragments cause positive less than or equal to 50% cancer in each fragment or core. And the last character is the PSA density, which is less than 0.15 nanogram per ml per gram. Now, how can we treat and manage this patient? This depends on the expected patient survival. If the survival is less than 10 years or is 10 to 20 years, or whether the survival expected to be more than 20 years. If the survival of the patient expected to be less than 10 years, then the choice is observation, while if the expected survival 10 to 20 years, then active surveillance play an important role here. While if the survival expected to be more than 20 years or equal to 20 years, we have many choices, which are either active surveillance or the external beam radiation therapy or brachytherapy, that's to say the radiation treatment. The other choice is surgery by radical prostatectomy. And after surgery, we have to look for specific features which are called adverse feature or for the presence of lymph node metastasis. The adverse feature are positive margin, seminal vesicle invasion, extracapsular extension, or detectable PSA. In these situations, radiotherapy also is required. Now, in this slide, we want to differentiate between the two options, observation and active surveillance. The observations, meaning involvement of monitoring the course of the prostate cancer, with the expectation to deliver palliative therapy. So here, we deliver palliative therapy for the patient in case of development of symptoms or change in examination or elevation of the PSA level. In this condition, we use palliative treatment only, while in the active surveillance, here is follow-up of the patient with delaying of the active treatment until the signs of progression to a more aggressive, potentially lethal cancer are detected. So here we can use the active treatment, whether radiation therapy or surgery or others, according to the findings of the disease or progression of the disease. But the patient has to undergo certain things, which are PSA every 6 months unless clinically indicated, digital rectal examination every 12 months unless clinically indicated, biopsy every 12 months unless clinically indicated, and also consider the multiparametric MRI. What is the indication of this test is if the anterior or aggressive cancer is suspected. When PSA increases and systematic prostatic biopsy are negative, here there is a role of the MRI. Yes. Now, the other risk group, it is called low risk group according to the NCCN guideline. The character of this group similar to these of the very low risk group, but include also presence of T2A. T2A here means that the tumor involves one half of one side or less. So in this condition, the risk will be low risk group for the patient. Now, how we treat this patient depended on the expected patient survival, whether less than 10 years or more than 10 years. If the patient expected life survival less than 10 years, now observation plays a role. While if the expected patient survival more than 10 years or equal to 10 years, here we have choice of active surveillance, radiation therapy, or radical prostatectomy in the same manner of treatment of very low risk group. Let's discuss here the radiotherapy management for patients with localized prostate cancer. Of course, we have two types of radiotherapy regarding the prostate cancer. These are the external beam radiation therapy and the brachytherapy. In the external beam radiation therapy, we apply the radiation by X-rays to the patient, and here we have also two types which are photon and proton. The photon external beam radiation therapy has many generations. The first generation was three-dimensional 3D CRT, while the other generation is IMRT. IMRT, it is the intensity modulated radiation therapy in which the radiation is applied to a specified area with less side effect to the surrounding tissue. And more recently is the use of SBRT, stereotactic body radiation therapy. Here, hypofractionation, 5 or less fractions of radiotherapy is given, concentrated. And also the daily prostate localization using the image guided radiotherapy, which is IGRT, is essential with either 3D CRT or IMRT for the target margin reduction and treatment accuracy. As I said, there is also the proton therapy, which is characterized by reduced exposure of normal tissue to the radiation beam relative to the photon therapy, but it is very costly and needs specific situations. Now, what are the benefits of external beam radiation therapy over the radical prostatectomy? First of all, external beam radiation therapy avoids complication associated with operation risk, such as anesthesia, and also these techniques are widely available and are possible for patients over the wide range of ages. The external beam radiation therapy has low risk of urinary incontinence and stricture, and good chance of short-term preservation of erectile dysfunction. And also, what are the disadvantages? Of course, as it has advantage, the external beam radiation therapy has disadvantage. And this disadvantage include the long course of treatment that over 8 to 9 weeks, and up to 50% of patients have some temporary bladder and bowel symptoms during the treatment. The other type of radiation therapy for patients of prostate cancer is what is called brachytherapy, in which we apply the radioactive seeds. These are mainly iodine 125, applied in the prostate. And we have two types of brachytherapy, as low dose rate and also high dose rate. And in this condition may be combined with IMRT or used alone. The use of only brachytherapy it's found to be only for low risk group rather than intermediate or high risk group. It is not beneficial for the intermediate or high risk group, but for low risk group the only use of brachytherapy is beneficial, while for the other risk groups of localized prostate cancer it is found when it is combined with IMRT give a good result rather than being used alone. Now, what are the benefits of brachytherapy? Brachytherapy has advantage as being the treatment is completed within 1 day, with little time lost from normal activities, and also is appropriate patient for cancer control rate appear comparable to radical prostatectomy, and it's of low risk prostate cancer to medium term follow-up. So it is beneficial for low risk group, and it is advantage as being only short duration for 1 day only. But also it carries disadvantage. So what are the disadvantages of brachytherapy? Disadvantages include the requirement of general anesthesia, and also the risk of acute urinary retention, especially if the patient undergoes transurethral prostatic resection. And also excessive voiding symptoms may persist for as long as 1 year after implantation of these seeds. Let's now discuss the radical prostatectomy. Actually, the surgery for the prostate is considered one of the complicated surgery in the body, and the surgical approach is one of the most complex operations performed by urologists. The outcomes, cancer control, urinary incontinence, erectile function, are sensitive to fine details in surgical technique. And no surgeon achieves perfect results, and outcomes vary dramatically among individual surgeons. And there are two types of prostatectomy, as either open radical prostatectomy or by robot-assisted radical prostatectomy. The routine perioperative anticoagulation is not used because of the increased risk of bleeding and lymphocele. There are many trials and studies applied for the radical prostatectomy. The most compelling evidence that selected patients with prostate cancer benefit over active treatment compared with watchful waiting comes from the Scandinavian prostate cancer group trial number. Here about 700 patients, unscreened men with clinically localized prostate cancer, over 23 years of follow-up. The radical prostatectomy compared with watchful waiting reduced the risk of death from any cause by 29%. The other study that is for the radical prostatectomy, it was called the PIVOT study. in a population of men subjected to widespread PSA screening. The benefit of surgery here was tested in prostate cancer intervention versus observation trial. And this trial was conducted in the United States on 730 patients with clinically localized prostate cancer. Compared the observation with the prostatectomy. From these two studies, they found the prostatectomy increased the overall survival but has many complications. The progression rates after radical prostatectomy depend on the clinical stage, biopsy, Gleason score, and serum PSA level before surgery, as well as the pathologic findings in the surgical specimen. After radical prostatectomy, the PSA level should become undetectable. Now, the other risk group after the very low risk and low risk group, it is what is called the favorable intermediate risk group. In this patient of favorable intermediate risk group, the clinical T stage characterized being T2B to T2C. Here we have many choices. Either the clinical T stage is T2B to T2C. This is meaning that tumor involves about more than one half of one side, but not of both sides. This is in 2TB, while in 2T2C, the tumor involves both sides. The other possibility of being patient with favorable intermediate risk group, that the Gleason score is about 3 plus 4, 7. That means it is 7 but 3 plus 4. And this is of grade group 2. Or the patient may have PSA level of 10 to 20 nanogram per ml. These features and the percentage of positive biopsy core less than 50%. So because of this percentage, the patient has a favorable risk group. Now, what is the best treatment for this patient? Also, again, depend on the expected patient survival, whether the patient has expected survival less than 10 years or equal or more than 10 years. If the patient survival less than 10 years, here the observation plays a role. While if the patient, and also here, because of being intermediate risk, less than 10 years expected survival, we have observation or use of the external beam radiation therapy or brachytherapy alone, here for the patient with favorable intermediate risk group. Whether the patient has expected life survival equal or more than 10 years, here the active surveillance also play a role, or the use of radiotherapy, or the radical prostatectomy. And the same, we have to look for the adverse feature or lymph node metastasis. If the patient has T2B or T2C, or the Gleason score is 7, grade 2, or Gleason score 4 plus 3 as grade group 3, or the PSA 10 to 20 nanogram per ml, but the more than 50% of the core is involved by malignancy. This is called unfavorable intermediate risk group. So now, what are the choices for treatment? Again, it depends on the expected patient survival, whether the patient has expected survival less than 10 years or equal more than 10 years. If the patient has expected survival less than 10 years, then observation plays a role. While if the patient has equal or more than 10 years, radical prostatectomy is a choice. Or in both situations, external beam radiation therapy plus the use of the ADT, androgen deprivation therapy, for 4 to 6 months. Or external beam radiation therapy plus brachytherapy plus minus ADT for 4 to 6 months. So here, in situation of unfavorable intermediate risk group, the ADT plays a role in different types of androgen deprivation therapy, or the use of the external beam radiation therapy together with the ADT, or combination of external beam radiation therapy and brachytherapy plus minus ADT. Of course, after these treatment choices, there will be undetectable PSA, whether after radical prostatectomy or after radiation therapy, and the PSA nadir should be less than 0.5 nanogram per ml. Otherwise, it's considered to be persistent or recurrent disease. Yes. The other risk group for the localized prostate cancer is high risk group or very high risk group. And here the patient will have clinical T stage as being T3A. Regarding the high risk group, we have the features are either T3A, in which the extra prostatic extension, whether unilateral or bilateral, or the patient has a glycine score 8, which of grade group 4, or glycine score 4 plus 5, which is equal to 9, which is under the grade group 5, or the patient has PSA more than 20 nanogram per ml. In this situation, the patient considered to be localized prostate cancer with high risk group. The other group, which is very high risk group, in which the patient has clinical T stage T3B or T4. In T3B, the tumor invades the seminal vesicles, while the T4 tumor is fixed or invades the adjacent structures other than the seminal vesicles, such as what? Such as the external sphincter, rectum, bladder, elevator ani muscle, and or the pelvic wall. The other possibility of being the patient within very high risk group, the primary glycine button is 5. In the glycine button we have, in the glycine score, we have two buttons, which are the button 1 and button 2. If the button 1 is equal to 5, here considered to be very high risk group. There's to be careful that if the button 2, 5, it is not very high, it is high, while if the primary button, not secondary button, is 5, now is considered to be very high risk group. The other possibility of being very high risk group, when the more than 4 cores with the glycine score 8 to 10, that is grade group 4 or 5. So in these situations in which the localized prostate cancer within the high or very high risk group, what is the best management? We have three possibilities, which are either external beam radiation therapy. Of course, these situations, these choices only when the expected life expectancy more than 5 years. We have the radiotherapy combined with the ADT as external beam radiation therapy, and the ADT for 2 to 3 years, and this is category 1 according to the oncology guideline. Or the combination of external beam radiation therapy with the brachytherapy plus ADT for 1 to 3 years, and this is again category 1, which is the preferred treatment. The other choice for the high or very high risk group is the radical prostatectomy together with pelvic lymph node dissection. When we choose each one of these three possibilities, we must have undetectable PSA after radical prostatectomy or PSA nadir after radiotherapy. Otherwise, we will have persistent or recurrent prostate cancer. Yes. In this slide, we will find the indications for the imaging test, including the bone scan and CT chest abdomen for whom? For patients with high risk group. And this who is characterized by being a very aggressive tumor when PSA more than 20 nanogram per mol, or when the biopsy Gleason score more than 7, Gleason grade group more than 2, or in the condition of advanced local lesion T3 or T2, T4, or the symptoms suggestive of metastasis disease. Here the imaging is indicated, like the bone scan, CT of the chest, abdomen, and pelvis. That's to say, like this picture, which is the bone scan showing multiple sites of involvement by the malignancy and the bone involvement. So the indications when the patient has higher risk group indicated for further tests as imaging tests, including the bone scan, CT chest, abdomen, and pelvis. Now let's discuss the androgen deprivation therapy. Of course, the androgen is implicated as the main etiological factor for the development of prostate cancer. And the androgen synthesis in men is the main circulating androgen is testosterone, 95% of which is produced by the Leydig cells and testes. The remaining 5% is produced from other areas, which include the adrenal cortex, synthesized from the cholesterol. And this androgen is implicated as the main cause for the prostate cancer. So when we do androgen deprivation, there will be decreased the risk, and we can control this malignancy. The androgenic effect on the body, it causes virilization and development of secondary sexual characteristics, development of prostate and seminal vesicles, an increase of the muscle mass, an increase of the bone density, and also it is responsible for the increase of the libido and the frequency of erection. This is the action of the testosterone on the body. So when we do androgen deprivation, we expect to have many side effects regarding to their action. The androgen deprivation therapy include surgical castration and medical castration. Surgical castration by orchiectomy achieves permanent reduction in circulating androgens, while the medical castration can be done by the LHRH agonists like goserelin, loprolide, triptorelin, or by LHRH antagonists, which include the degrelix. Of course, when we use LHRH agonists, we have to be careful for the flare-up. So we have to cover the patient for anti-androgen for 7 days or more before giving him LHRH agonist. Now, what are the side effects of androgen deprivation therapy? Of course, the androgen deprivation therapy has many side effects, including the hot flash, vasomotor instability, and these are the hormonal side effects, the most common side effects. And as is increased the bone density, the testosterone, so osteoporosis is expected to be in the patient who has androgen deprivation therapy. So before the use of the ADT, we have to send the patient for a DEXA scan, and also we have to cover the patient with the use of certain drugs, include the calcium, about 1,200 milligram, and also vitamin D daily. And also sometimes we use as prophylactic denosumab or zoledronic acid. There is also another side effect is the greater incidence of clinical features of obesity and because of insulin resistance, also alteration of the lipids, greater risk of diabetes, acute kidney injury, cardiovascular disease. So all these features, the patient can develop all these features when he undergoes the ADT. And sometimes we use intermittent ADT to decrease the side effects of this treatment. Now, at the end of the lecture, I wish if you can share your opinion about this case. 62 years old male, newly diagnosed as prostate cancer with a Gleason score 4 plus 3, which equals 7, and PSA of 18 nanogram per ml. The question is, what are the further steps required in workup before starting treatment? And if it is localized cancer, for which risk group this patient belongs? And what is the treatment? The other question is MCQ. For a healthy male, 64 years old, comes to your medical oncology office 6 months after completing 8 weeks course of external beam radiation therapy for his T1C Gleason score, 3 plus 4, that is equal to 7 Gleason score. His pre-radiation prostate specific antigen was 6 nanogram per ml, and today is 1.2 nanogram per ml. He has no rectal bleeding or dysuria. He is concerned about residual cancer with his PSA still being measurable and inquire what further therapy is needed. We have 4 choices. I wish if you select the appropriate one. A. Salvage radical prostatectomy. B. Continued surveillance with a repeat PSA in 6 months. C. Total androgen blockade for 6 months. And D. New sessions of radiotherapy. References of this lecture from different textbook of oncology: the Vita textbook 11th edition, ASCO SEP 6th edition, in addition to the last version of the NCCN. Thank you.